everybody to the National Academic Half Day. We are very glad to have you guys here and making the time. I know it's usually on a Wednesday or a Friday, but thank you for being here anyways. Today we have an exciting lineup of speakers. We are very grateful for their time, and we have an exciting lineup of presentations. So Dr. Fremes will be presenting on cabbage conduits, and Dr. Ruel will be talking about mid-cab and robotic cabbage today. So just a little bit of intro about Dr. Stephen Fremes here. He completed medical school at the University of Toronto in 1979 and then entered surgical residency in 1979 in University of Toronto. He was a recipient of the Heart and Stroke Research Fellowship from 1982 to 1984 during his residency, where he completed his master's under Dr. Richard Weisel as well. Dr. Fremes is currently a cardiac surgeon at Sunnybrook Health Sciences Center and a faculty member at the University of Toronto. And he's been a faculty since 1989. He was the head of the Division of Cardiac Surgery at Sunnybrook from 2000 to 2013 and is a professor of surgery at the U of T. He is the inaugural recipient of the Bernard S. Goldman Chair in Cardiovascular Surgery. And as we all know, he's a very prolific researcher, and his primary focus is on clinical trials of myocardial protection and coronary surgery. Most recently, really spearheading the up-and-coming Stitch 3.0 trial. Dr. Fremes has authored more than 300 papers, including numerous guidelines for AHA, ESC, SDS, and CCS. He is certainly a world expert on this topic, and we're quite honored to have him present today at our National Academic Half Day. So Dr. Fremes, thanks. Thanks again.
Okay, so can you hear me all right?
Yep.
Okay. All right, so these are my disclosures. I have a bunch of slides. And this will be, let's see, at 3 o'clock, Mark takes over, right?
Yeah,
So,
that's correct.
okay, so this is the outline of today's talk. And the 2021 AHA revascularization guidelines gave these recommendations for arterial conduits. However, the standard operation remains lead to LED and SVGs to non-LED targets. These are the revascularization, relevant revascularization guidelines for arterial conduits, starting in 2016 with the STS and 2018 with European, 2021 American, and in 2023 there was a joint society publication. They didn't end up being guidelines, but rather best practice statements. These are largely focused on arterial conduits. As you can see, in the last two sets of guidelines, radial received a higher level of recommendation than beta or reta. The 2023 joint publication also talked about the gastroepiploic and also saphenous veins, both endoscopic and no-touch saphenous veins, which were also discussed in the 2018 European Revas guidelines. In the 2021, these were mentioned as best practices, but not specifically guidelines. So what is the patency of a vein graft? Well, this is a meta-analysis of over 40,000 patients. And it was determined that at 1 year approximately, patency is 11%. Now, what causes vein graft occlusion? So this is the general schematic. On the left side of the slide, you see injured epithelium or endothelium from surgical trauma. And then over the next year or so, you end up getting neointimal hyperplasia, and then later on, atherosclerosis. And the time frame is usually early 1 year and beyond 5 years. So the vessel at 1 year looks like the second panel, and over the course of time, you end up getting a more atherosclerotic appearance. So what about the other ones? Well, this is a meta-analysis from 2023, individual patient meta-analysis of trials that included postoperative angiography, not necessarily trials of conduits themselves. And the LIDA graft failure rate was 9.7, not LIDA occlusion, but LIDA graft failure. RITA was more than 23%, and that's, I would say, quite variable from study to study. Radial 13.8% and vein about 19.7%. So I would say that the LIDA radial and vein graft are what you might expect, but RITA seems to be different than what someone would expect. Risk factors for graft failure were age. The older you are, the more likely you are to graft failure. Female is typically associated with graft failure. Smoking is or ongoing smoking is, and statins are protective. In the same study, it determined whether graft failure was associated with adverse outcomes. That's sort of what we consider to be one of the principles of behind the benefit of coronary bypass, that you need to have patent grafts. Although more recently, it's been less clear. In any case, MI, repeat revascularization, were associated with graft failure, both before and after imaging, and death was as well. And here's the Kaplan-Meier curve for patients who did not have graft failure and those who did have graft failure, the primary outcome being late MI or repeat revascularization. In another recent trial, this was the VEST FDA trial, that luminal non-uniformity or lumen abnormalities, not necessarily graft occlusion, but lumen abnormalities are also associated with repeat revascularization and MACE. I mentioned RITA. This is another meta-analysis that we participated in. And in here, the pooled patency of the RITA was 90%. Again, vein graft, about 20% occlusion, no touch RITA and radial artery had not dissimilar patencies. So we'll now talk briefly about endoscopic. So one thing that endoscopic harvesting is very good at is reducing wound complications. This is wound infection on the left, and if you use a more generic term, wound complication, it looks very similar. However, in this meta-analysis, which involved more than 250,000 people, there was some concern that there may be increased graft occlusion. Now, these were all observational results within randomized trials, but it is concerning. In studies looking at endoscopic harvesting using OCT, it was shown that experience was important. The experienced ones were doing this more than 30 times a month and had more than 900 cases. The novices had less than 100 cases. And they looked at OCT of harvesting, and they also looked at early graft occlusion by CTA. And they did find that harvester experience was associated with injuries to the grafts, and that graft injuries were associated with graft occlusion. So this stimulated the regroup trial, which was a VA trial, and they did include all experienced harvesters. And the patients were randomized to open versus endoscopic harvesting. And the primary outcome on the right was similar between the two groups. And when they were seen over a longer term, there was also no difference in MACE between the two groups, suggesting that clinically experience is important, and in experienced hands that endoscopic harvesting is not associated with increased adverse outcomes. So these are the best practice statements um, from the joint publication that EVH reduces wound complications. Patency is concerning, sorry, patency data is concerning that the large RCT show no difference and that more evidence is necessary. So the other nuance is no touch, and this is the no touch vein. For those who haven't seen it, looks like a pedicled artery, where the vein is associated with that. And the vein technique was initiated a single center in Sweden, and they followed the patient sequentially at approximately 18 months, 8 years, and 16 years. And they found that the no-touch vein graft had preserved patency at very long follow-up. And in fact, they found that the patency was not materially different than the LIDA in the same patients, the LIDA all going to the LAD and the no-touch going to non-LAD vessels. Whereas there was progressive differences between the no-touch and control veins. There was one very large trial comparing no-touch veins conventionally harvested from China, more than 2,500 patients. One thing that's notable is that graft occlusion was quite low in the control and the experimental group. However, even in this situation, with single digit occlusion rates, there was a benefit of no touch. In this study, the wound infection rate was greater with no touch harvesting. There's another large trial from Nordic countries, and it has not been published to my knowledge, but was presented at ESC. And the primary outcome was a composite of vein occlusion, PCI to a study vein graft, or death. And the primary outcome did not differ significantly. I think you might say that this study was underpowered, as they were postulating a very high control event occlusion rate. The point estimate of vein graft occlusion did favor the experimental group, although it did include 0. A network meta-analysis without the most recent study showed that the no-touch and the radial artery were the two best conduits in terms of randomized evidence. There's not a lot of randomized evidence for the RITA as opposed to observational data, but within the randomized trials, the two best conduits have been shown to be a no-touch SVG or a radial artery. And these are the best practice statements. The randomized data show that patency is significantly better. There's no clear evidence of better clinical outcomes. And the most recent study would also be consistent with that. As well, that the use of the no-touch vein is associated with more harvest site complications. Some additional thoughts about vein grafts. Standard of care is usually single antiplatelet therapy. However, in this network meta-analysis, DAPT, either clopidogrel or with ticagrelor, was associated with better graft occlusion results in the single antiplatelet therapy alone. And last year, we published new antiplatelet update. And in terms of surgery, it was recommended that DAPT is standard of care in patients with or without ACS. I would say traditionally, it would be favored after ACF, but the aggregate evidence would say that it's also useful after surgery for chronic coronary syndrome. And for ACS, that perhaps stronger P2Y12 inhibitor is better than clopidogrel-based ADAPT. And why is that? Well, that's because of mortality benefits seen in ACS trials, Plato and Timmy 38, although these primarily PCI trials, and cabbage was a post-randomization variable. In other words, these were the results in patients who had cabbage, but um, the heart team decided whether patients would have cabbage or not. The randomization was according to the antithrombotic therapy. And this is the algorithm. And for it's separated as to whether you have off pump or on pump surgery. Um, for off pump surgery, it's for to improve both patency, and MACE for off pump surgery, sorry, for on pump surgery to improve patency. As well, statin therapy is important. And this is a class 1 recommendation. And as I showed you before in a recent meta-analysis, that statin use was associated with better graft patency results. Moving on to the RITA. So this is a network meta-analysis of beta versus CETA for mortality. And it's a cumulative meta-analysis, which means that these studies are organized sequentially, chronologically. So for more than 20 years in observational studies, it appears that there's a strong mortality benefit with the use of beta rather than CETA. And the point estimate really hasn't changed very much, just the confidence intervals have become smaller. However, there's been one large randomized trial using a clinical outcome. And I expect that everyone in the audience knows that this was neutral, that the primary outcome, which was mortality at 10 years, was identical in the two groups. The secondary outcome was 3-point MACE, death, MI, or stroke, and this was not significantly different either. However, if you looked at as treated results, you did see a benefit of multi-arterial grafting. And this was both for death as well as for death, MI, or stroke. So the LITA is typically used in situ. It may sometimes need to be used as a free graft, but it's largely used in situ. The RITA, on the other hand, often doesn't reach where it has to go. And it could be used in situ, but it may have to be used as a free graft. And as a free graft, it could be used very commonly as a composite off the LITA or off the aorta, which we would not do very often, or off SVG hood, which is the way we would do a free graft. It was coming off the aorta. This is from the Cleveland Clinic, which is a beta capital. And they did look at results according to the RITA configuration. And the worst seemed to be when it was off the hood of a vein graft, whether it was off the aorta, whether it was in situ, or whether it was off the LITA, the results were all more or less the same. And when it was used for the LAD, the RITA and LITA were identical. And this was very similar to results that were published much earlier in Melbourne, where they found that the patency of both the LITA and RITA were very similar when they went to the LAD, and also very similar when they went to the circumflex. So the most standard operation is the lead to LAD and SVG to other conduits. And this is sort of an algorithm of how to get to more complex arterial grafting. The next step would be using the radial artery, which is used very much like a vein graft. Beyond that is in situ beta, and then doing sequential arterial grafting, and finally doing anti-aortic OPCAB with multi-arterial grafting. And as I said, this is usually more necessary for the RITA than the radial artery. This is another slide from the Cleveland Clinic. Again, Dr. Paquin's the main author, and it tries to identify how to use the second mammary. And if the second mammary is used for multiple targets, then the results are better than if it's used for only one target. And he also goes through the size of the target vessel. And essentially, the more myocardium that's perfused by the second ITA graft, the better is the outcome. So one of the problems with beta harvesting is sternal infection. Um, the RITA is a very important, or sorry, the ITA is a very important organ for sternal perfusion, along with the internal thoracic arteries. So it's become accepted that skeletonization is a good strategy in terms of reducing sternal infection, but there is some evidence that perhaps it's also associated with worse ITA outcomes. And this is a secondary analysis of the COMPASS trial, which was comparing rivaroxaban plus aspirin, or aspirin alone, on graft patency. So the randomization was the antithrombotic strategy. So comparing skeletonized and pedicled results is an observational result within a randomized trial. But look at the second, and third column. The graft occlusion results were much worse in those who had skeletonized grafts versus pedicle grafts. And if you look further down, this even included to the Lima LED. And if you do one thing right, it has to be the Lima to the LED anastomosis. So there was even some concern that the results to the LAD were affected. And this was also associated with adverse outcomes. Here are Kaplan-Meier curves of MACE and repeat revascularization, and those who had skeletonized grafts had worse outcomes compared to those who had pedicle grafts. So these are the best practice statements from the Joint Society publication for RITA that the patency data is mixed. And there really is no clear evidence within the randomized trials of better patency for the RITA. Observational data does support the use of RITA compared to SVG for survival and other adverse outcomes, but the only RCT, which was quite a large RCT, was neutral. Beta harvesting is associated with a higher risk of sternal infection. That's accepted. Skeletonization likely is associated with a decrease in sternal complications, but there are concerns about skeletonization on patency and cardiovascular outcomes. So now I'll talk a bit about the radial artery. So the best evidence for the radial artery, and the reason it was given a class 1 recommendation, is that there is evidence to say that it improves clinical outcomes. Now, this is an individual patient meta-analysis of studies which were primarily graft occlusion studies. However, when you aggregated the data, there was a reduction in MACE, death MI, or repeat revascularization in those who had a radial artery as a second conduit compared to a saphenous vein. And also, this was associated with a difference in graft failure. And this is the forest plot for the various risk factors for the clinical outcome. And there were a few treatment effect modifiers. It was more evident in those who were younger. It was strong. It was much more effective in women compared to men. And I'm not sure if that means that the radial artery is better in women or that the vein is worse in women. But the treatment effect was very strong in women. And also, renal insufficiency was a risk variable. And that's interesting because these were all trials with angiographic outcomes, and usually there is a cutoff for renal function to allow you to be in the trial. But despite that, um, renal insufficiency was concerning in terms of adverse or increased radial artery occlusion and also increased clinical outcomes. So these were all angiographic trials, and perhaps repeat revascularization was triggered in part because they had an angiogram and you saw stenosis. But this is an extension beyond 5 years, the same patients, and they were just followed clinically. And we did see that death in my stroke was better in those who had a radial artery. And in addition, mortality was better, although it was not substantially better. So although the original study may have been affected to some degree because the patients had a protocol driven angiogram, in this later study, it would, I think, is stronger evidence to support the radial arteries compared to a vein graft. There are some caveats. You shouldn't use it following transradial catheterization. That moderate rather than severe stenosis is associated with string sign. The meta-analysis I talked about excluded the VA study, which was the largest trial, because they did not publish their later results until more recently, and their later results did not show any survival advantage. Now, it is true that their early results did not show any patency benefit either, and the reasons for that are unclear. But that is one of the caveats in terms of the radial artery literature. And also, in general, calcium channel blockers have been used, and the use of calcium channel blockers may limit the use of other more strongly supported guideline-directed medical therapy after bypass surgery. So this is the 2021 American Revasc guidelines. Class 1 indications were for LIDA to LAD or IMA to LAD and a radial artery. And the reason that the radial is higher is because within the guidelines, randomized evidence takes priority. And the radial artery is supported by randomized evidence. The LIDA to LAD is supported by non-randomized evidence. And beta is a 2A recommendation, again, supported by non-randomized evidence. On the right-hand side, you see best practices for the use of the radial artery. And in the Joint Society best practices, randomized data supports better patency. The radial artery harvesting is generally very well tolerated. It should be used to graft a target of low competitive flow, or in other words, severe target vessel stenosis. And at least observational evidence supports vasodilators within the first year. So this is a large network meta-analysis of largely observational studies comparing RITA, radial, and vein grafts as a second conduit. And basically, RITA and radial do very well against vein grafts, statistically better in terms of long-term outcomes. Although there's no difference between radial and RITA, and deep sternal wound infection is higher with the RITA. So these are some of the considerations in terms of the choice of conduit. And one is the patient stable? Does the patient have a long life expectancy? You know, that even someone who's older may have a long life expectancy, but typically that relates to the patient's age. Is the LV size and function acceptable? Is this an isolated CABG procedure, or is this a valve CABG or aorta CABG procedure? Is the ascending aorta healthy, or do you have to avoid touching the aorta? are all the potential grafts available? Have they had vein graft stripping? Um, if it's a redo, probably an ITA has already been used. Are there any specific contraindications to use of different conduits? What are the non-LED targets? And where will the LED be grafted? And this has to do with primarily where the ITAs can reach. And if you're going beyond that stepwise approach or the first steps, what's the local expertise for multi-arterial grafting? Remember that radial artery is sort of the beginner step, insight ureta is the second step, and aortic is the pinnacle or final step. Also, complete revascularization is the intent in general for every patient. Incomplete revascularization is associated with worse outcomes. Some of the benefits of surgery versus PCI are based on the fact that surgery in general is better at achieving complete revascularization than PCI. However, are there, on an individual patient basis, does this particular patient have features that make complete revascularization challenging or more hazardous? And maybe for an individual patient, incomplete revascularization is safer in the short term. In any case, these are all sort of things that go through your mind when you're looking at the patient, looking at the angiogram. So what about the risk factors for harvesting? They differ for each of the individual or the main conduits. For a vein graft, obviously, if they've had stripping or varicose veins, if they have leg edema, probably wound healing of the lower leg's a problem. And if you have peripheral vascular disease, wound healing of the lower leg is going to be a problem. If they've had bypass grafts, perhaps you want to avoid that leg entirely. If they have multiple risk factors for wound infection, they're at higher risk of wound infection, at least from open vein harvesting. And in terms of wound harvesting, the results are mitigated by endoharvesting. So the main complication of beta is sternal infection. So things that would increase the risk of sternal infection or sternal dehiscence or prior chest irradiation, this COPD or particularly emphysema, ongoing smoking, older age, and I would say older than 70 typically. If you do have multiple risk factors for wound infection, if you have subclavian disease, the affecting that particular ITA, you have to have a different strategy for that ITA. And wound infection is certainly mitigated by skeletonization. So as far as the radial artery, the ischemic complications are very, very, very infrequent, although it depends on whether the patients have adequate ulnar collateral circulation. Also, you would like it to be of a reasonable size because it's always used as a free graft, and you would like it to be large enough to suture to the aorta or to an ITA easily. So the proximal end should be large enough, and usually we'd want it to be more than 2 millimeters distally. As well, it is not as resistant to atherosclerosis as the ITA, so the quality needs to be good. If patients have vasculitis, we think it should not be used. If it's been instrumented, should not be used. As I mentioned, renal insufficiency. For one, there's evidence that graft failure is higher, but also if they have marked renal insufficiency, it's potentially going to be used for dialysis in the future. Vocational reasons. So a musician, dentist, surgeon, gemologist, these may be reasons why you should avoid using the radial artery, not because the hand's ischemic, but there may be slight sensory nerve changes that occur, which would interfere with that person's vocation. We've said that ipsilateral breast surgery, axillary dissection, radiation um, are a contraindication, but I think that depends on the extent of the surgery. In any case, most of these complications or potential complications are mitigated by vascular lab studies. So we would use normally modified Allen's test plus a lab-based vascular assessment. And then there are some target vessel features. So a vein graft can reach any target vessel. A RITA in situ can reach the mid-LAD, the main right coronary. Some people say that a skeletonized RITA can typically reach the posterior ascending, and the proximal circumflex. A radial artery can usually reach all targets as an aorcoronary bypass, perhaps the most distal right coronary branch or most distal circumflex branch may be difficult as an aortic coronary graft. So the severity of target vessel stenosis, or in modern day terms, FFR positivity, not important for the SVG. For the RITA, we usually say that a moderate stenosis is satisfactory for left, but severe for the right. And for FFR, it is important. For radial artery, severe for left and critical for right, and FFR is important. Composite grafting, off Alita, it's usually a bailout strategy for a vein graft, although the surgeon, Dr. Kim at Seoul, had excellent results using a vein graft and no-touch vein graft off Alita as a composite graft, as the only composite for the entire heart. However, typically in most people's hands, it's a bailout strategy. A RITA can usually reach the distal circumflex, posterior ascending plus or minus. The radial can typically reach the posterior ascending as a composite. Sequential grafts using a vein are straightforward using the vein graft, and it's a good strategy if the vein graft is limited. It's certainly more challenging using the RITA. It's less challenging using the radial artery. So there are some comparative studies, RITA versus radial. And this is the one major randomized trial, RAPCO, and they've reported at 10 years, and they've reported at 15 years. And at 10 years, and I'll also say that the RITA was not used in situ, it was used as a free right internal thoracic artery, or FRITA. And the group in Melbourne were quite comfortable doing that, and they actually reported very good results using a FRITA in observational studies, but it also made it the trial cleaner. In any case, patency was better, statistically better in the radial artery than the RITA, according to intention to treat, and survival was better as well in those who received a radial than a RITA. Now, when the patients were followed up to 15 years, MACE remained. There was no more repeat angiography, but MACE was reduced in those who had a radial artery versus a RITA. And survival was better, although not statistically better, in those who had radial artery. So there's a lot more observational study comparing the two. And this is a composite of 12 matched populations. And overall, the survival in those who had beta was greater than those who had a radial artery. Although, in truth, in the first 10 years, you can read the lower row, just a second, the lower results. The first, the two groups were identical. And after 10 years, there was a survival advantage with the beta. And that's seen on a landmark analysis on the right, where the origin is starting at 10 years. And that's sort of, I think, what you might expect, that if patients have survived 10 years, probably the people who had the beta would have a better long-term outcome. Beyond that, because the beta biologically should be identical to that of the radial artery, sorry, to that of the LIDA. Um, but within the first 10 years, their survival was the same. Early on, this is results from the STS. Operative, sorry? Okay. Early on, operative mortality favors the radial artery. Can I just take a pause for a moment? We have some competing voices in the background. I'll see if there's a problem. I'll be back in a couple of minutes. Okay, all good. Um, Now let me continue sharing. Are you able to see that?
We can for sure.
Okay. So on the left side is operative mortality, and operative mortality favored the radial artery multi-arterial grafting versus the RITA multi-arterial grafting. And external infection obviously favored the radial artery multi-arterial grafting strategy compared to beta. However, there is a volume outcome relationship. And in the highest quartile of beta utilization, there was no difference in operative mortality between radial artery versus beta multi-arterial grafting strategies. So how often is arterial grafting used? This is STS, and it was about 10%, although in the last few years it's starting to increase. And it's most recently, I think, 16%. In Ontario, this was a population-based study that we did. It was more than 20%. This is from Europe. And in the Sweetheart Registry, where we do get a lot of information, it was only used in 4%. Although in a multi-center registry in Europe, it was 34%, and in Austria, it was almost 17%. In Japan, the RITA is used very commonly. This is a total arterial revascularization study. And the reason I'm showing this is that not that total arterial revascularization is better or worse, is that how often total arterial revascularization is used in certain jurisdictions. And it was used in 30% of all patients in Australia. So in Australia, using arterial grafts is essentially the norm. So do arterial grafts work? Well, I've showed you a number of studies which suggest that they do work. But this is a study using the STS data and National Death Index for follow-up. And there were 1 million patients, of which there were 50,000 beta patients and 50,000 LIDA radial patients. And survival was greater. Survival, not event-free survival. Survival was greater in those who had multi-arterial grafting, whether you had beta or radial. And this was true in all sensitivity analyses. So volume outcome is important, but in the study, a volume of 10 cases annually, or no, in other words, 1 per year, was associated with reduced risk-adjusted outcomes. So only a very low volume is associated with worse outcome. There are a couple of trials that will be published coming up. One is Roma, and this is the study design of Roma. It's international unblinded 4,300 patient trial comparing multiple and single arterial grafting. And it's the second arterial graft is directed to the circumflex. And in the experimental group, they can have additional arterial grafts. And the choice of the second arterial graft, radial or Rita, is according to a surgeon's choice. And the primary outcome is event-free survival over 5 years. It's funded by CHR. Many of those in the audience are in institutions where they participated in the study. And it is one of the largest trials ever in coronary surgery. And follow-up was completed last year, and we expect to report results either 26 or 27. When Roma stopped recruiting, we can continue to recruit women. And the new trial is called Roma Women. There were less than 700 patients, 700 female patients in Roma. And the idea is that at least 1,300 more patients will be recruited. So altogether, there'll be 2,000. Now, it has been funded by CHR, by the UK British Heart Foundation. It's been funded by the Austrian Health Agency, a private foundation called STAR. Did not get funded by NIH, but an application's been resubmitted. And recruitment to that is going so well that the plan is to recruit 2,000 new patients, which should be done by the end of next year. Now to switch to transit time flowmetry. So on the right upper panel, you see flow wave of something that's occluded. It gets revived, and you get amazing flow. And usually the cutoff you like to see is above 30. Immediately after it's revised, it's higher than that, and that's probably because flow-mediated vasodilatation. And later on, a few more minutes, it's 34 with a pulsatility index of 1.7, which is speaks to the resistance in the system. So this is consensus statements, and these are the consensus statements. And there was very high agreement by all of the individuals, and I would say that the individuals included in the consensus statement were pro transit time flowmetry. But even despite that there was a very high level of agreement for every single statement. So it should be used in every case. The probe should be a reasonable fit. Apparently, the results are different if you look distally versus proximally. Now, I think in practical terms, you shouldn't lift the heart to put the probe distally. But potentially, if you're doing off-pump surgery, you could do it as immediately after the graft is completed. It is reasonable to do them before and after protomy, and that's because there could be graft thrombosis after protomy. The flows are dependent on the systemic arterial pressure, and mean pressure greater than 80 is recommended. If the flows are arguably low, that you should try and increase the pressure. So what is acceptable pressure? Well, you'd like to see it above 30, and you'd like to see a pulsatility index less than 3. Although if it's really low, and that would be less than 15 or even less than 10, it's likely a problem. And if the pulsatility index is greater than 5, then that's a concern. It may be that it's just kinked. It doesn't necessarily mean that the anastomosis is occluded. But you should evaluate further to see if there's a problem. Now, whether you should or should not revise shouldn't be solely on the basis of the transit time. It may have been just a terrible vessel and it was done to the best of everyone's ability and it couldn't possibly be improved upon. So you do have to use clinical judgment. Here's an algorithm. The only thing I would say is that if in your institution you also have a high frequency ultrasound probe, you might be able to see an anatomic reason for graft dysfunction. In other words, you might see that there's a dissection in an ITA. You might be able to see that there's some graft failure of a distal anastomosis. To our knowledge, there's been only one clinical trial of transit time flowmetry or graft assessment versus no graft assessment. This was done a number of years ago at our institution, and it ended up being underpowered. However, this was the conclusion that routine intraoperative assessment was safe, but did not lead to a marked reduction in graft occlusion 1 year after bypass grafting. And the incidence of vein graft failure remained high despite contemporary practice and routine graft surveillance. So we had done earlier studies where we looked at a graft occlusion within the patient's same hospital stay. And we did see advantages of graft assessment, but this was looking at graft failure 1 year, and the failure rate was very similar in those who did or did not have graft surveillance. Now, just to show that's still important, this is a figure from the VEST FDA study. And on the top, female sex is a risk factor for graft failure. Endoscopic harvesting is a risk factor for graft failure. Now, the graft level ones, TTFM flow and TTFM pulsatility, they look small, but this is because flow and pulsatility are continuous variables. And reduced flow is associated with higher graft occlusion, and higher pulsatility index is associated with higher graft occlusion. So I'm now going to talk a bit about hybrid, and for those who are in residency, particularly in their final years, are probably thinking about what you're going to do as a fellowship. All the things in green are common things to consider for fellowship, but in red is coronary surgery. And, I would say that it's not unreasonable to think of coronary surgery as an area of subspecialization. So what is hybrid revascularization? So typically, or by definition, it's a LIDA LAD and PCI of non-LAD vessels. It's typically off pump, but it could be on partial support or even conceivably full support. It's usually minimally invasive through a small left thoracotomy. It could involve a robotics, although it could be transsternotomy. It could be LIDA LAD bypass through a sternotomy and then PCI of non-LAD vessels. As far as staging, LIDA LAD is typically first and PCI is later, although it could be reverse stage. It can also be done at the same sitting, but in most situations, in most institutions, it's not. Now, who is the best hybrid candidate? Well, best would be a complex LAD lesion, which does not look favorable for PCI, with a good target vessel, an epicardial target vessel, whereas the RC and circumflex lesions are fairly focal, they're not complex, and because of the fact that non-diabetics relative to diabetics have a better outcome with PCI, the patient should be non-diabetic, and they have good LV function, because in general, the patients with good LV function will tolerate the operation better. And the worse the ventricular function, the more that CABG is recommended as opposed to PCI. So, why? Well, it combines the benefits of CABG and PCI. CABG, the lead is constructed to the LED, and the lead is the most durable of revascularization strategies. PCI is less invasive. The early risks of PCI are less, and this includes stroke, but overall recovery is faster. And for the minimally invasive part of the operation, the recovery is faster, and cosmetically, it's nicer. And patients do appreciate cosmesis. We do know that whereas syntax score doesn't really affect the outcomes of CABG, it does affect the outcomes of PCI. And that the results of PCI in non-diabetics using later generation DS are quite good. So sternal sparing, maybe this is an advantage in the future should they need another cardiac operation. And let's say you're a farmer, and it would be nice to get back to the farm and be able to do heavy work after bypass surgery, and you can do that earlier if you've had a minimally invasive operation. So some other situations, well, some patients may not have any other conduit options. A porcelain aorta may be a contraindication for multi-vessel bypass in centers who are not skilled or do not have the skill for multi-vessel anti-aortic CABG. Certainly, transfusions are reduced. This is helpful in patients who cannot accept transfusions. Sterile infections are reduced, so useful in patients of very high risk for sterile infection. And perhaps it's helpful in some patients prohibitive surgical risk. However, they do have to be able to tolerate one lung anesthesia. I suppose it is possible to take down the LIDA with partial bypass support if they can't tolerate one lung anesthesia, but I've not heard that being done. And I think, although it is generally costly, on a societal basis, it may be cost savings because of earlier return to work, etc. But in some very high-risk patients, it may be cost saving to the institution. So this is a schematic of a robotically assisted lead LED bypass. And if you do the bypass first, you can check the Lima LED anastomosis. There you see a fairly straightforward PCI circumflex topic. And there you see the result afterwards. With robotics, you can see the coronary target well to begin with before you're committed, and you can see the IMA quite easily. And the visualization is much easier this way than through direct vision through a small thoracotomy. And then one of the ports is converted to a small thoracotomy for the bypass. However, it can be done through direct vision, and it can be done with both ITAs, and both the ITAs can be grafted together in a minimally invasive fashion. This is from Leipzig, who've had a very long interest in minimally invasive surgery. This is from a center of excellence in the United States called Advanced Hybrid Coronary Vascularization, where both ITAs are harvested robotically. They're sutured to one another, and then the lead is used for the LED. They're read to one or more branches in the OM circulation, and the right is later on treated with PCI. So there's been several meta-analyses. Most of the studies are observational. The randomized trials have been all very small and too small to show differences in clinical outcomes. This one was published in 2022. 5-year mortality was slightly higher with hybrid coronary vascularization with an OR of 1.55, although not statistically different. MACE was the same. Short-term, reduced transfusion statistically, shorter length of stay statistically, reduced acute coronary insufficiency statistically, all favoring hybrid coronary revascularization. Repeat revascularization was higher with little heterogeneity with hybrid coronary revascularization. It seems like early on that includes both the LAD revascularization, but as experience grows, primarily the non-LAD targets. And here's mortality on the left is early, so quite similar between CABG on the right side of one and HCR on the left side of one. Between 1 and 5 years in the upper right panel, no statistical difference between. By 5 years, no statistical difference, but largely because there was a single outlier where the results strongly favored CABG. Another meta-analysis in the same year, 2022, a greater number of studies and patients, and the results short-term multiple variables were statistically better with hybrid coronary revascularization, no short-term difference in death or MACE. Short-term, there was an increased repeat revascularization, potentially related to the LAD. Long-term, higher repeat revascularization. Long-term MACE similar. But in this study, death was lower. Although in this study, the number of trials that looked at death long-term was fewer than the other. So I would say that death is probably similar. I'm going to finish up with a few other things. So CT FFR is coming. I mean, the quality of CT imaging is just better and better. And the FFR is not yet standard of care, but I think within the next 10 years will become standard of care. I would say there's still many patients where the images have a lot of where images with calcification or prior stents have artifacts, but I think there will be algorithms to try and remove those. Now, the nice thing about that is that if patients have this before an angiogram, you'll have a pretty good idea as to whether the patient should have surgery or whether it's reasonable to do PCI in that patient. So it'll reduce the number of ad hoc PCIs. And it's already a class 1 recommendation for stable ischemic heart disease or in intermediate or high-risk patients. There has been a trial called Fast Track CABG, and this was interesting. All these patients did have an angiogram, and they all had triple vessel disease, and they all were graftable, and it was all felt to be appropriate that they have surgery. But they also had CT FFR, and the surgeons who operated only saw the CT scan and the CT FFR results. And the surgery was done safely. There was fairly high congruence of what was recommended from the angiogram and what was recommended from the CT FFR. So I'm not saying you should do surgery using only CT scans, but it just shows you that within a research protocol, it's good enough. And within the next 10 years, I'm sure it'll be so much better than what you're seeing right now. So a case. So we have two cardiac surgical residents discussing choice of conduits. We have Bob and Gail. Gail says, Bob, this morning's patient has triple vessel disease, mildly depressed LV function, is scheduled for ACB 2 to 3, Lima plus or minus Rima radial. What goes into the decision-making for the choice of conduit? Bob says, Gail, great question. I think the best way of thinking about this is that there's some general and specific considerations, but let's review and then discuss. So some general considerations. Patient stable. Does the patient have long life expectancy? Is the LV size and function acceptable? Is this an isolated CABG procedure? Is the ascending aorta healthy? If the answers are yes, then we are more likely to use beta. Bob, great points. I thought of some specific considerations. Are all potential grafts available, or are there contraindications? What are the non-LED targets, and will the grafts reach easily? What is the severity of the target vessel stenosis? What is the local expertise for multi-arterial grafting? Gail, great points. I think most likely we'll need to use the ITAs as a composite for the LED and circumflex and use the radial for the PDA. Also, given the diabetic status, skeletonization of the ITA should reduce the risk of sternal infection. Also, the RCA is completely occluded, so there's little competitive flow for the radial graft. Thanks, Bob. I understand the decision-making much better now. So also important is social justice, shared decision-making, and a heart team approach, which can not only discuss PCI versus CABG, but can also discuss choice of conduits. So coronary disease is worldwide. Actually, in North America, it's relatively less common than in some places of the world. It's really terrible in Northern Africa, the Middle East, Eastern Europe, and Asia. But this is what's happened to the age distribution in the United States. And this is projected to this is only going to get more significant over the next 20 years. So as the older 65 group gets larger and the middle-aged group gets larger, there's going to be a lot of coronary disease. So for those who are coronary surgeons, they're going to be very busy over the next 10 to 20 years. So these are the conclusions. And thank you. So I'll stop sharing. And
Thanks, Dr. Fremes, for that thorough presentation of CABG conduits. So this is a time now to ask questions to Dr. Fremes about anything that he's presented today. Please use the raise hand function in Zoom if you have any questions at all.
And if I can just
It looks like there's a question in the chat from Sidra. So we are seeming to consistently find that grafts work differently in women than men, with women benefiting more from arterial grafts. Have there been any studies looking at why that is the case? For example, have there been biological/genetic reasons cited for these differences?
Okay, I'm back.
Hi, Dr. Freems. Sorry. We do have a question in the chat. You want to just read it out?
Sure.
So Sidra from U of M is asking, we are seeming to consistently find that grafts work differently in women than men, with women benefiting more from arterial grafts. Have there been any studies looking at why that is the case? For example, have there been biological genetic reasons cited for these differences?
Biologically, I'm not sure. I would say what's known more is for non-obstructive disease than for graft disease. And there's that's a very hot topic. But for graft disease, no, I don't know. I would say that I wouldn't include RITA in arterial vascularization for females, though, because beta is associated with more sternal infection in women. And female is usually considered to be one of the risk factors for beta in women. And I would say in general, because of the age of women, when they do get coronary disease, there are, many of them are not young. And if they're in their 70s and older, they would have further risk factor for strokes infection. On the other hand, the radial artery works very well in women, and whether that's because the radial does work better, or whether that's because the vein graft works worse, I'm not sure. I think it may be more the latter.
Thank
Thanks,
you.
Dr. We have another question from the chat. It's from Massine, and he's saying, "Thank you for your presentation, Dr. Fremes. Is there a place for robot LAD revascularization for young patients with single vessel disease compared to PCI on the LAD?"
Yeah. Well, I think that's probably what Mark Ruel will talk about. But the short answer is yes. I would say this is an opportunity for high-income countries or middle to high-income countries, as opposed to low or low to middle-income countries. But I would say of the patient, if you're a non-diabetic and it's a type A lesion, stenting the LAD is not a bad option. And the patients do recover very quickly. On the other hand, if it's a lesion with restenosis, if it's a complete occlusion, if it's a very complex lesion, or if it's maybe including the LAD, sorry, including the left main, that doing a robotic LAD bypass is a good option. Now, I have no experience with doing robotic anastomoses, and many of the people who do use a robot for bypass surgery do the anastomosis under direct vision. A smaller number do it robotically. But I think for it to really be useful in very high-risk patients, it's more the patients who are having robotically than those who are having it in open anastomosis.
Great. Thanks, Dr. Freems. Another question from the chat. It's from Jimmy. How do you currently weigh the competing evidence in RITA versus SVG in your patients? Large observational studies favoring beta long-term, whereas we've seen controversial results on the post-hoc analysis of the COMPASS trial with greater than 20% RITA occlusion rate.
Mm-hmm. So this is just about RITA beta. So we use skelnizations very selectively, and it's done by very experienced harvesters. So in other words, the experience is probably important, and we don't use it routinely. We only use it when we think it's going to make a material difference. We do think that as the biology of the RITA and LITA are likely the same, that the differences you see or the variation you see is probably related to the surgeon and the way the operation's performed, as opposed to the conduit itself. Within ART, the crossover rate was quite high. In other words, it suggests that the surgeons were not very comfortable, or a number of surgeons weren't very comfortable with adhering to the protocol and delivering a beta revascularization strategy successfully. What we do is we typically use it in younger patients as opposed to older patients. It's much more commonly done in men as opposed to men and women. And we try and do it in situ. And then if we can't do it in situ, we do a T graft and use the Rita to the lateral wall. Overall, we use the radial more commonly than we use the Rita, in part because we use the radial almost regardless of age. But um, but we use both.
See, thanks. And I just had a question about your approach to the proximal anastomosis of radial artery to the aorta. Do you directly anastomosis to the aorta, or do you do it off the vein hood?
Well, yes, but most of the evidence that shows a benefit of radial artery use direct aortic anastomosis, and that's what we do most commonly. If it's a very small radial, we may not. If there's limited space on the aorta, we may not. If the radial's a bit short, we may not. And the radial it's easier to sew a composite anastomosis with a radial artery than a Rita, but most commonly it's directly to the aorta. Some people say it's better to use a smaller punch, a punch less than 4 millimeters as opposed to a punch 4 millimeters or larger.
Thanks, Dr. Fremes. Does anybody else have any other questions? Otherwise, we'll let Dr. Fremes go, and we can take a break before Dr. Ruel begins his talk as well.
Okay, goodbye, everyone.
Thanks,
Nice meeting
Dr.
you all
Fremes.
virtually, and enjoy the rest of the afternoon. I'm sure Dr. Ruel will all have you mortgage your houses and buy a robot. So enjoy
Thanks
the rest
again.
of. Okay.